Thank you very much. Today we have a very exciting panel bringing us various perspectives on game changing and data. First, we'll hear from Dr. Moreno Owens, who is well known here in Cincinnati, I understand. Then Dr. Andrew Beck will be speaking about the linking of geography and health data. And finally, Doug Bill Harris, who's Vice President of Customer Strategy and Activation at 8451, which will explain to you what that is. Each of our participants will speak for about 20 minutes, and then they'll take 10 minutes of questions immediately following. I've asked Tiffany to provide, well, wherever she went. We'll have microphones out in the audience so that we can hear people. Some of our participants will be using slides, some will not, but I think all of them will speak from the podium. Is that right? Okay, so I'm going to begin with Dr. Owens. Dr. Owens is currently President and Chief Executive Officer of Interact Health and Interact for Change. He is a physician with a long-standing innovation work in obstetrics and gynecology and has been a leader here in the Cincinnati area, including serving as the Hamilton County coroner, I was surprised to see. And his talk is entitled Data More Than Just Numbers. Thank you, Dr. Owens.
Thank you. I guess I'm going to do a little bit different talk from the data because I'm the activist, I'm the agent of social change. I'm the one that takes that data that's generated and puts it to life. Your conference today is game-changing data, and for me, it really needs more data to more of a call to action. Recently, Interact for Health is the Old Health Foundation. We are a convergent foundation created when Humana bought out Choice Care. Choice Care is a physician-owned group. The funds from that by state law says you either have to give it to a nonprofit, you can't go for a for-profit, and the Health Foundation was created in 1998. Our focus today is on three pillars. We focus on tobacco, we focus on school-based health centers, and we focus on the heroin addiction. But we look through a lens of equity. So school-based health centers, we're focusing on those schools that had at least 500 students on Medicaid. For the tobacco, we're focusing on the fact that the smoking in this country has dropped, not in poor people. Poor people, the rate of smoking is still high. So we want to focus on that group, a very disparate group. And of course, on the heroin, it's just a national issue. But I want to share with you some things from my various career and how I looked at data and how I respond to data and try to put that data to life. Most recently, we released, and we do multiple releases of data and surveys. We work with the University of Cincinnati on. And we released a survey on the number of women who felt that life was very stressful. So we put this data together, we released it as a two-pager. And when the TV stations came to interview me about our release, and at the end of the conversation, she looked at me and she said, "Now what are you going to do?" And I was a little shocked because I thought I had already done it by giving you the data, creating the narrative, having you go back to your station and share with millions of people. But it really struck me that sometimes we don't do enough. I want to share with you how data has impacted my life and my various careers as a reproductive endocrinologist. You said you were surprised that I was a coroner. But when I was a coroner, I ran on the platform, the higher the graduation rate, the lower the homicide rate. Anything I've ever done in my career still is very low to my oath as a physician, to work with people who are not at ease. That's for diseases, people are not at ease. So things that I've done is always connected to working with poor people and certainly working with children. I first want to talk to you about a single point of data and what that can mean. If you give me simply the percent of free lunch at one of the Cincinnati public school, I can give you a profile of that school on a single piece of data. We'll start with free lunch, the percent of free lunch. Cincinnati public school ranges from 37% to 100%. I had a program called Graduation with Achieved Dreams. At one of the schools, it was 100%. That means that every single child in that school is on public assistance. So what does that mean? I can tell you. I look at the data. That means that 76% of the kids are with a single parent. May not be mother or father, but they're coming from a single parent home. 76% of those kids. I'll tell you the reading scores, the math scores are low. I'll tell you that school probably is ranked as a D, maybe even F by the state, on a single data point. If you're at 37%, that's Walnut Hills. Because that's a mixture of kids who are middle class and kids who are poor, and the numbers are different. All across the board, a single piece of data. When we talk about childhood poverty, it's also interesting that when the news came out about 3 years ago, 3.5 years ago, that Cincinnati, the city of Cincinnati, ranked number 2 in poverty. Oh, the city was upset. How could it be number 2? And then people wanted to try to massage it. Was that number 2 across the whole country? Is that number 2 of cities of like size? What does that really mean? And then next year they said, well, no, we're really only 5th or 6th. But was that the issue? No, the issue is the poverty. Whether it be 2, 8, 10, or 12, or 15, 40% of children in Cincinnati live at the poverty level. 72% of children at the Cincinnati public schools at the poverty level. At the poverty level. Now, I'm going to give another look at the data about Cincinnati public schools and how they can lead to action. Only 50% of children in Cincinnati are ready for kindergarten. 50%. What does that mean, ready for kindergarten? That means you can count to 10, you know your colors and your shapes. Wow, not rocket science. Think about that. But only 50% are ready due to some of their social determinants. There are kids that come to Cincinnati Public School that don't know their first name. What is your name? Little boy, Red, or Pete. And yet society says we got an even playing field. You're surprised that a corner runs on a ticket of the higher the graduation, lower the homicide rate, because they mean if you raise your graduation rate 10%, you lower your homicide rate by 20%. But yet on the front end, only half the kids in any urban area, whether it's Cincinnati, Chicago, New York, Los Angeles, Atlanta, are ready for kindergarten. So you have that child who's also exposed to lead. The lead rate in Cincinnati and places like Cleveland are high. And the society says, well, we're going to lower what we consider a normal rate of lead. Any lead causes brain damage. We don't accept that. So this kid that we said is not ready for kindergarten, it's got lead levels in the brain. And if you're poor, you hear 850 words a day. If you are blue collar, you hear 1,200 words a day. And if you're upper middle class, like you in this room probably are, your children hear 2,500 words a day. So that same child at the age of 3 is behind 30 million words. 30 million words by the age of 3. So what's your best shot? But taking all those numbers led to the good people of Cincinnati passing the preschool promise that sit on the board. Preschool promised an extra $15 million to take 3-year-olds and 4-year-olds and put them in quality preschool, not daycare, preschool. Give them a chance to be ready by kindergarten. So you see, it's important. If you are able to be ready for kindergarten, then you have a great chance you can read by 3rd grade. You see, from kindergarten to 3rd grade, you learn to read. After 3rd grade, you read to learn. You're not ready to put down. When I was a coroner, I read an article about private prisons, and one of the data points that they look at in terms of deciding to put a private prison in your area is 3rd grade reading score. It is that diagnostic about that child's future. How? Unfortunately, you're 9 years old, and you're faced with deciding not all due to your issues. But sometimes looking at data, it's just not just looking at data. Sometimes you must be culturally competent to understand the data. I'm going to give you a couple examples. Congestive heart failure. The ability of the heart muscles get damaged and they can't pump. Therefore, the blood doesn't get pumped out of the heart, you don't get enough oxygen, and you live a very sedentary life because you get medication to strengthen that heart. If you look at white women, the most common cause of congestive heart failure in white women is coronary artery disease, where the coronary arteries begin to become narrow, therefore blocked, not supplying enough blood to the heart. However, for African American women, the most common cause of congestive heart failure is hypertension. Now, why is that important? It's important because of the intervention. My intervention for white women is to get them on a diet and exercise early. My intervention for black women, diet and exercise, but treat the hypertension. Not only get them on the medication, but to make sure they're at the goal. You see, in this country, we talk about hypertension, but most people don't realize that only about 45% of people who are on hypertensive medication, 45% are at the goal. At the goal of what we consider to be normal. Take the medication, get to a normal level, and you will not have the impact of hypertension. So you got to be culturally competent to understand your intervention is going to be different. Another example is Pima Indians. Pima Indians in the United States have the highest rate of diabetes. The highest rate of diabetes. That's only true for Pima Indians who live in the United States. Not the Pima Indians who come from Mexico who live in Mexico. Why? They work hard. The reservation. And we can document the rise of diabetes with the initiation of the Owens reservations. But also talk about hypertension. People were wondering one time why Pima Indians was so hard to get them that goal, because they didn't understand the culture that Pima Indians fast. And what happens as a physician, you get them a prescription saying, take one pill 4 times a day or 3 times a day after meals. Well, when they fast, look at their prescription. After meals, I'm not eating for the next week. Medication not taken. After the fast, they may eat 7 times. And they were taking the pill 7 times. So yes, you can have data, but sometimes you need to have the cultural competence to understand what your data really means. Political awareness. One of the things we do is tobacco. And one of the things we work on is smoking 21. We want to see the age of tobacco being raised to 21. We want to raise the tobacco tax. New York City has the highest tobacco tax in the country. It's about $4.50 a pack. But New York City has the lowest smoking rates in the country. Let us cross the bridge to Kentucky. To Kentucky. The tobacco tax in Kentucky is 60 cents. 60 cents. And guess who has one of the top smoking rates in the country? Kentucky. North Carolina is number 2. Guess who's also number 2? State for growing tobacco. North Carolina. Now you gotta understand things. Now if you raise the tobacco tax 50 cents, you say, wow, that's a big jump. Has no meaning to teach, has no meaning. You must raise the tobacco tax by $1 to have impact. 50 cents, the tobacco companies will give you a coupon for 50 cents. They can't handle $1. And teenagers, if you want to lower the smoking rates of teenagers, raise the tobacco tax by $1. $1 is the amount that seems to have that impact. Again, it's about understanding the data and the action from that. Somebody asked the question once, we're getting our data about the heroin. And this also talks about how data can be political. One of the things we want to do is offer needle exchange. It's just next day. Our goal, we're responsible for 20 counties in our charter. And we want to try to get needle exchange at least in every county, or at least to have a mobile unit that can go between counties for needle exchange. But when you say needle exchange, it ruffles me. Oh, you are enabling. It's not needle exchange. When you come for a needle exchange, you must answer 50 questions. 50 questions. That's how we're getting our data. This is just not giving you a needle and saying goodbye. It is getting you information, it is drawing blood, and offering you an opportunity to treat. But getting those questions is how we found out that 21% of people who are on this road of drug addiction started with a dental appointment. It started from a dentist, not from a physician, from a dentist. People weren't paying attention to the dentist. Indeed, I went to the dentist 2 months ago, had a dental procedure, was given 12 Oxycontin, I only used 1. So they're 11 in my medicine cabinet. That's how it gets started. Your children take those 11. Someone else steals your medication. You're selling your house. One of the ways that drug addicts do it, they look for opiates. When people are showing their homes, and they distract the real estate agent, go look at the cabinets and steal the prescription drugs out of the cabinet. A needle exchange, as I said, calls political. So sometimes we now say harm reduction. It's about the harm reduction because it tells us about hepatitis C. If you think that the heroin is an issue, it's the hepatitis C that I worry most about. Hepatitis C will cause liver failure and it leads to liver cancer or liver transplant. The cost is going to shoot up. To treat someone today for hepatitis C is $80,000 if you respond the first time. And you know in this country, if you have a use of a medication that dramatically increases, the price goes up. The price goes up. So we can gather data, a lot of data, in needle exchange, but we have to fight off the political aspect, and sometimes we have to shift the name to harm reduction to get acceptance. I'm thinking this will impact all of us. None of you are immune from this. You may say, I don't do the drugs, but you're going to pay for it with a higher insurance premium. You're going to worry about your daughters when you start dating someone who once was a drug addict. And you must remember the new wave of middle class people. The new wave of heroin was 96% rock, not black. And people always say, well, why is that? Well, you can find academic papers that will tell you that when African Americans came to the emergency rooms, they were getting powerful medication. They said, no, we don't give this to black people because they'll give it to them. They give it to whites so we can see what we are. But even when you sound the alarm, when I was a coroner, because being a coroner in Cincinnati also means you run the forensic laboratory. So I was responsible for all our drug testing. In 2007, I announced in Cincinnati two major things. One, that more people were dying from a drug overdose than a motor vehicle accident. And motor vehicle accidents numbers were not down, they were up. Also announced in 2007, it was the first time that people who were dying from a drug overdose, there were more people dying from prescription drugs than illicit drugs. From prescription drugs now, not the illicit drugs. It made page 3 or 4 of the newspaper, not much was said. And that's one of the reasons we are where we are with the heroin issue. It's because people got addicted to prescription drugs. The government finally clamped down. They can't get the drugs, so they turn to the heroin. When you hear next about it's not going to be the heroin, it's going to be meth, people will go back to meth, and that's worse. Highly more addictive and associated with a lot more crime. See, that's the other piece where people step back and say, well, I'm not involved in that. It's the crime that's going to touch you. It's going to be the person that's in your car, bring it to your house. It's the economics of this. So I'll end, of course, my 20 minutes. What I'm asking is that for you who do the research, I appreciate it. You do because I'm the one who take that data and I'll go out and I'll do the fight, I'll do the advocacy, but I think you have to do it as well. So that's all everybody has to do. You have to do it as well. Because you see, one day when you reach your maker, whoever that is that stands for your maker, it's not going to be enough to say, I worked at UC or worked in the police department, I did the data, I raised my own family. No. What did you do to help others? Who did you advocate for? You have that data, bring it to life, advocate. Thank you for giving me the tools to do the things that I do. Ten minutes of questions. Yes.
I would like to see a show of hands in the room from anyone who has a family member or loved one who has an opioid addiction.
It's very, very common. If we were in a Cincinnati public school classroom and asked the question, who's known somebody who's been a homicide victim, or raised somebody a homicide victim, half the class would raise it. Half the class would raise it. Questions?
There's one over there to your left.
Yes.
So I don't know, with this opioid epidemic, what about how it's affecting those chronic pain patients that need access to so how is that being addressed?
The question is, people with really chronic pain, how's it going to be addressed? First, let me just give you a little context to understand this. One of the things that started this is that physicians were being sued. Physicians were being sued by patients because they said, you're not giving me enough medication. I'm suffering. I'm going to sue you. So that's the reason doctors. So then pharmacy came up and said, hey, doc, I got this great pain medication. It's not addictive. We were told it wasn't addictive. So I'm getting sued. I'm going to give you medication. I'm going to give you 30. I'm going to give you 60. I'm going to give you 90. Sometimes the physician lazy says, I don't want to hear from you for 3 months, so I'll just give you 90. People walk into the emergency room and get that. So the question is, how do you handle chronic pain? We got to look for other things. We got to stimulate the pharmaceutical companies to come up with medication that truly is non-addictive. We have to use other things, maybe acupuncture, pain medication. There are pain medication specialists that have subjects with spinal cord, putting medication in your spine to block some nerves. So there are some things to do. It's going to be tough because people are going to look at you suspiciously. When I was a fellow, people who were addicted knew the system. So they would call, knowing that you were covering the practice, didn't know them at 9 o'clock at night, asking for pain medication. You see, they say, I'm a patient of Dr. So-and-so, you're recovering from Dr. So-and-so, and so you would call the pharmacy and give them 30. We learned to be on 1 day's worth. You say, okay, tomorrow I'll call Dr. So-and-so. So we have to change what we really do. Yes?
We have, in this city, one of the largest and most successful health information exchanges called HealthBridge. We talked to them over the years about how to use their data for research. They have a lot of data that's through that system every single day. And the answer we get back is that the legal people, the lawyers say that they will not permit data to be shared because of HIPAA and other regulations. My response was this can be readily identified and used in a very productive manner. We do a lot of research here at the College of Medicine, and we cannot get access to that data for research. How do we as an institution change that thinking?
Well, I thought that the health collaborative was being part of that narrative and changing that. Because they got a very large grant, and I thought part of that grant was to be able to start using that data. Because even Interact for Health was saying, how can we work to find out, work with the systems on identifying the smokers? But I think we have to always take the higher level and say, this is it. You know, when you look at smoking, 41% of all deaths in the United States are somehow related to smoking. We got to put that narrative out to the public, and we have to get the public to speak up and say, yes, we want better answers. And I think we have to get more advocacy. That's what's going to take to do it. It's going to be advocacy. And that's what I'm asking you to do as well as data researchers, is to be the advocate.
We will continue to try.
Thank you. I appreciate what you do. Yes.
The data tell us about the difference between the crack epidemic of the 80s and opioid epidemic of today, and what can we learn from that, and how can we solve more problems?
You know, that's a great question. I smile because it's a very controversial question. You see, crack people are going. When you look at things through the lens of equity, Interact for Health and other organizations spend a lot of money to say the Cat House. The Cat House is the center where they treat drug addiction. To create more beds, to treat the heroin. Through the lens of equity, the people who will get that burden will be your alcoholics, and your crack people won't be a bed for them. Because the new soup of the day is the heroin. Well, it points out, unfortunately, it's going to be people uncomfortable, but it points out the racism in our society. People were cracking, all of a sudden, you could walk into a police station in Massachusetts and turn over your heroin. You had a crack person walking to the police station and get arrested. There is bias. And if it's not racist, it's implicit bias. I know people here say, well, we're research, we're not. But let me tell you a story coming out of Harvard School of Business. People looked at a symphonies across the country, realized women weren't being represented the way they thought they should be. So they wondered if there was an implicit bias. The people who were doing the judging were artistic people, right? I said, no, we have no bias in us. This is what everybody sees. So the Harvard Business had people audition, but they put a curtain and they put a carpet down. Why the carpet? So you couldn't tell the high heels walking across the stage. And guess what? Women's selected went up 30%. So there wasn't implicit bias. Let's look at ourselves. And I would say to any of you, go to the Harvard website and take the implicit bias test, and you will shock yourself. Anyone who takes it black or white, you're going to be shocked about your own implicit bias. So we know that's pure racism. When you start having people talk about arresting the dealer in the heroin, they never said that for crack. Crack's been the first arrest for crack cocaine in Cincinnati was 1984. It's never been said that. It's affected only 4% initially, the first few years, of people dealing with heroin are African Americans. 4%. So that's bias. As I said, you can find academic papers where we just didn't give African Americans narcotics because we know what they were addicted. And so by doing that, they missed the professor who walked in, it was the lawyer who walked in, it was the doctor who walked in, who was getting the prescription. Those are the people who are addicted today. The issue is, for all of us, if we look at a state like New Hampshire, where the unemployment rate is below 4%, they can't find employees. Because the rules say, oh, if you've had a conviction and arrested for drugs, we're not going to hire you. Now they got to go back and rethink that. But they need them for the workforce. Another question?
I have a question for you.
Yes.
How can we best prepare young children for a future that increasingly both relies on data and monitors them in ways that may not be obvious? For example, our cell phones, knowing that we're all sitting here in this room together.
Say it again.
How do we prepare children? What thoughts could you have about how we can work on grammar school curriculum that might help kids think about this future that's invisibility of data that is driving marketing, is driving healthcare decisions, policies?
Well, I'm going to give you a straight answer. It certainly won't be for the ski kids because they learn that email.
Yep.
And for When you talk about research on African Americans, you're very suspicious about research. You know about the Tuskegee. You may not know the Tuskegee study. Everybody knows that study? Syphilis. Whether that African American man suffered with syphilis for 43 years. Who knows the treatment, how it bad. So you have the suspicion. Cell phones, again, when you look at it, only, I think about 35% of people don't have internet still, especially in New York City, so they don't have that connectivity anyway. And they have a phone, but oftentimes not a smartphone, but a phone with that you pay for the car. I think if you're going to do that, how do you do the data? When I was president of Cincinnati State, our biggest challenge in getting down to the elementary school kids and junior high kids was getting them to rethink how factory work would be. They're thinking factory work is that dirty, dark place. And it's not all about computers. It's about robots. You're building that robot, repairing that robot. So you can do that and actually show them and taking them there. It's very difficult, I think, for kids to conceptualize data, the significance of data in our lives. That's the hardest part. When they want money. So they're saying, I don't want money, I don't want to be poor.
So one of the things I do worry about is perverse incentives. People willing to be self-monitored in a way that provides more monetary gain and may trade off privacy for some support. And I think it's predatory. Sometimes we've done research, hopefully not too much. But I think we have to expand the conversation. But I like very much your idea of helping them think about analogies that are already familiar with them to them and how they might be different, like ordering food or getting a bus. Thank you.
Any other questions? I appreciate your attention.
I'd like to introduce now Dr. Andrew Beck, who is a pediatrician and a population health specialist. His focus is on the social behavioral determinants of health and how they may provide us with an opportunity for mitigation of some of the other causes of healthcare problems. He's also well known for his contributions at the intersection of healthcare and business, and his talk today is using data to prioritize equity, patient by patient and neighborhood by neighborhood. Thank you, Dr. Beck.
Thank you. Let me first just say, as my slides note, that it's both, I'd say, motivating and somewhat intimidating to follow Dr. Owens. I think locally, when we think about advocacy for the work that I'm a part of at Cincinnati Children's, there are few advocates as strong as he is, and I think it keeps us motivated to do the jobs that we so want to do. The things that I really want to talk about today is how I view data as a key contributor to informing the work that we do, to motivating us to work even harder, and to then importantly track the outcomes for the efforts that we are putting into place. And it's in this context that I'm going to talk, and I'll give it a moment. The areas that I will focus on, too, that I believe to be highly complementary to what you just heard from Dr. Owens is this concept of using data as a storyteller, using data, again, to motivate, and using data as a way to inform the work that we do to help us best meet the needs of our patients and families while also seeking equity. Again, with my title, I'll say patient by patient as well as neighborhood by neighborhood. And so I'm going to try and move the slides myself, but I'll tell you.
I gave up pretty quick.
Oh, there we go. We got one. All right. So what I'm going to talk about mostly is data in the context of social determinants of health, and this term that we coined called geomarkers. This idea of thinking about place as a vital sign in some respects when we see patients and talk to patients. And then I'm going to talk a little bit about how we put this into practice both in our patient care as well as our population health initiatives. So I got one, let's see if I'm going to get two. There we go. So I'm a physician, I'm a pediatrician. I think in your brochure it says I'm a PhD. I cannot take credit for that. I never did a PhD. But I did do an MD, and I think one of the things that clinicians in the room know is that a lot of our learning occurs patient by patient, case by case. And so what I'll describe is a case that we at Children's see all the time. I work both in primary care and on the hospital wards. One of our most common diagnoses in pediatrics is asthma. One of the most common reasons for children to be hospitalized is asthma. And so I present to you a case that I see just about every week that I'm on the inpatient service. And in this particular case, it's a young man, it's a boy, who comes to us with difficulty breathing. He's wheezing, he's coughing, he can't catch his breath. We may find, looking at the chart, that he's used the emergency department in the past, perhaps he's been prescribed a controller medicine in the past. But we don't necessarily always dive deeper than that. What instead we do is say, well, this is an asthma attack. We're going to put you on our evidence-based protocol for asthma management. We're going to throw a lot of respiratory medications your way. We're going to put you on some steroids, maybe some oxygen, and hope you get better. And most of the time, pretty quickly, these kids get better. And in about 24 to 48 hours, they go home. Now, what's missing from that particular case, what's missing from that conversation, if we stop there, is any sense of thinking about preventing the next episode from happening. These kids keep coming back into the hospital for the same symptoms. They miss school days, parents miss work, and the cycle continues. So what can we think about besides going backwards? I'll get the hang of it, I promise. Is what else might we know about this child? Again, based on where they live, about aspects of their past experience, what might predict or inform their clinical course both in the short term and importantly for us from a preventive standpoint in the long term. How can we ensure that they don't keep coming back, but that instead they keep going back to school, keep staying healthy, and not having difficulty breathing? And so what might we know from a data standpoint merely by knowing their address is one thing that I think we thought deeply about. Now, the term social determinants of health was brought up a few moments ago by Dr. Owens. I think this is an area that increasingly we in medicine understand is exceedingly relevant to health outcomes across the life course. Not just health outcomes, you mentioned third grade reading, you mentioned high school graduation. A lot of these same outcomes that are life outcomes are similarly affected by the context in which one lives. Now, I won't read this definition, but I will highlight how I interpret it. This is one of the most common social determinants definitions you'll see. It's from the World Health Organization. Many other organizations have similar types of definitions. How I would boil it down to is what is the context? What is the life situation? What is the environment in which you live, grow, work, and age? And for kids, what do we think about the job for kids? It's growing, it's learning, it's hearing words, it's going to school, it's developing along their normal trajectory. So what are the potential aspects of life that affect that trajectory? What is the context? And in large part, I would argue that you could say place is a key contributor to this. So a couple years ago, there we go. A couple years ago, a lot of you probably saw this in the city paper. How many people saw this map? So it's essentially a map of the neighborhoods of Cincinnati. They call out a couple neighborhoods on the west side, a couple neighborhoods on the east side, and illustrate a few key measures within those neighborhoods. The kind of eye-opening one being life expectancy. Now, for those of you who know Cincinnati, you'll know these neighborhoods, but suffice it to say, they also provide some details about the racial population, the percent minority, and the marker of poverty. And what you can see is that about 3 miles between places like Lower Price Hill and Hyde Park or Mount Adams, about 20 plus years of life expectancy, a huge variation in both the percent minority, detailing decades of structural racism and segregation, but also extreme differences in median incomes, poverty between these particular neighborhoods. Again, illustrative of the differences that we see between context and an outcome like life expectancy. And again, for those of you less familiar with Cincinnati and these particular neighborhoods, I've tried to continue to try and show some pictures of these neighborhoods. I might just have if someone's back there and wants to advance the slides and put me out of my misery. You can click the next button. You'll see some pictures of these neighborhoods, and again, providing the visual context in which one lives, something that so often as a physician we don't see, we don't know. I think this provides a key illustration. You see Lower Price Hill here, boarded up buildings, and if you press again, you'll see Hyde Park with the classic Saturday morning farmers market. So if you could advance. So one thing that we commonly think about probably in this room from a data standpoint is hard numbers. So what are the numbers behind this? Well, I think there's also the importance of the stories, the qualitative piece too. And I did just want to share a few quotes from patients and families that have been hospitalized at Cincinnati Children's for asthma exacerbations. I would read them to you, but I'm honestly not going to, I'm going to step forward because I think they're powerful to just see. So the first one, my window is broken, there are roaches, my landlord isn't responsive to my concerns, illustrating the housing issues that so many of our patients face. Another notes that it takes 4 hours to get to the pharmacy, 2 hours to get there walking, and 2 hours to get back. I just can't do it. So for those of us who prescribe medicine, think about the hypertension medicines that were mentioned just a moment ago. There are often so many barriers to actually picking up the medicine that it may not just be a matter of whether you take it or not, it's a matter of whether you pick it up. Similarly, I don't have transportation. I had to catch the bus everywhere. It was really, really hot the next day. By him having a breathing problem, I was scared to catch the bus. And the last one, I was in the hospital with no money, no one, no food, no gas. It was just horrible. I'm basically eating nothing but cereal or a little scrap that she doesn't eat that I can sneak in before the doctors come and see. This is the reality for a lot of the patients that I see week to week, day to day on the hospital wards. If I am more concerned about providing just the medicines, I'm really missing the boat. If you could advance. The concept of equity was also brought up. So what is equity? What do we think about when we think of equity? There's a definition here. The way I think about it is figuring out how we can best match the need to the resource. So if you provide the same exact care to everyone, the same evidence-based asthma care, we're not necessarily going to achieve the same outcomes that we so desire. An equity focus is more of an outcomes focus. We want to achieve the best possible outcomes. That may not necessarily mean providing the exact same care to everyone. If you advance, you'll see a figure that I think can be really helpful. Many of you have probably seen versions of this figure. There are several versions of this figure. But it provides, I think, an illustration of what equity means, what the equity mindset means. And so if you look at this, you see a couple different things here, right? You see kids trying to watch a baseball game. I think it's a Rockies game. I'm a Pirates fan, but still, one would assume that they want to watch the Rockies play. But you see that the ground differs beneath their feet. You see that the fence differs, obscuring their view. But if we provide the same supports, that same box, it still isn't going to solve the problem. One kid might be able to see the game, the other two might not. Now, equity would say, let's try and figure out how to provide the necessary boxes so that they can each see the game, so that they can each achieve the outcome they desire. And if you advance again, you'll see there's a whole other concept here that we're not really talking about, this concept of justice. Why is that ground a different height? Why is the fence there in the first place? I think those are other questions that we may think about to grapple with from an advocacy standpoint. But in the case of equity, how do we think about providing those necessary supports? So if you advance, we'll see how we've started to think about this for patient and population health. And let's go to the next slide. This is a slide we commonly think about and commonly show in our realm of pediatrics. So again, asthma is one of our chronic disease. I'm showing a histogram here. On the y-axis of this graph is the asthma admission rate per 1,000 children per year. And on the x-axis are the 90 or so neighborhoods in Hamilton County. So if you look from left to right, you can see extreme variation. Some neighborhoods have admission rates in excess of 20 per 1,000. Some on the far right have admission rates of about 0 in some cases. Huge variation from left to right. You can also see just some markers that allow us to ground these in context. You see the county admission rate, and the best data that I can find for a national admission rate. Again, some neighborhoods in excess of 10 times the national rate. Now, one of our key areas of focus at Children's is Avondale. So if you advance, I think I highlight Avondale here. So this is the neighborhood in our own backyard here in Cincinnati, the neighborhood that the hospital abuts. And we know in Avondale that we have an asthma admission rate that's about 4th or 5th across all 90 neighborhoods. If you advance, we also know that it's many times higher than the county rate, many times higher than the national rate. So what is it about a place like Avondale? What is it about the neighborhoods that are in the dark red that are different from the neighborhoods that are not, that are more on the yellowish side, that we may think about to help inform the care that we provide to motivate action towards equity? So if we advance, we also know that it's not just asthma. We started with asthma because that was an area where we knew this is a chronic disease of childhood. We knew that it's sensitive to social and environmental factors, but it turns out that pretty much everything is. So I showed 3 more histograms here. And again, I don't expect you to read the neighborhoods at the bottom. I only expect you to see that one of these is preterm birth, one of these is psychiatric admissions, and one of these is all-cause inpatient bed days, any reason for children to be hospitalized. And what you can see is there's the same variation, right? You move from left to right, you see steady variation such that some neighborhoods contribute a disproportionate amount of morbidity and some do not. And I can tell you that by and large, it's not perfect, but by and large, the same neighborhoods are on the left of each one of these curves, and the same neighborhoods are on the right as well. And so if you advance, it's really motivated us to think about what might we do differently to say, make the neighborhoods on the left achieve the outcomes of the neighborhoods on the right. And just some numbers behind the magnitude of the problem. We have paid particular attention to this concept of all-cause bed day disparities. How many days do children spend hospitalized? These are days they're in the hospital sick instead of home or at school, parents missing work. And you can see that as we look across the board from poorer neighborhoods to wealthier neighborhoods, we see pretty significant differences here. And so the magnitude of the problem is such that if we were to achieve the same inpatient bed day rate that the least impoverished neighborhoods achieve, we would save years and years of days in the hospital every year. That's the magnitude of difference. That's the magnitude of possibility. So that's the motivation piece, right? So we have some informing by knowing these associations between context and outcome. The motivation piece is the extent of the problem that might be narrow if we advance. And we can keep going. So one of the things we've thought about to inform and predict is how can we use the concept of biomarkers commonly present in the medical lexicon and use it to inform the way we think about health outcomes from an equity mindset. And so this has brought us to the concept of the geomarker. So if you could advance the slides, you'll see how we've defined these. So this is a common biomarker definition that you'll see in the literature. We have adapted it thinking about what place-based contextual factors might help us inform or predict incidence of outcome or disease for either individual patients or perhaps populations. And if you advance, we'll show how we've used these. So let's start with Avondale and asthma. So again, you recall the child I introduced at the start. One of the things we've begun to think about is how might knowledge of neighborhood inform the way we provide more equity-focused care. And so here's a map of Avondale. These are primary care patients. The red dots are those children who carry a diagnosis of asthma. So this may have power in and of itself to show where our patients live, where there might be pockets of asthma. But if you advance to the next slide, I would say that there's increasingly understood power in overlaying different data elements. This may be useful in and of itself. It may be more useful with added information. So if you advance, we think about asthma and housing. So now we add a layer of blue. There's a density function here where the darker blue represent more dense areas of housing code violations. So here is where the health department or the building departments from Cincinnati have found violations of city ordinance. Common things like mice, cockroaches, mold, things we know to be associated with bad asthma. And so the power of merging these data is to illustrate patterns for that particular child, but also perhaps across populations. And so one of the things we recently did was show these maps to our partners at the Legal Aid Society. And they looked at the blue, they looked at the red, they thought about where they were active and said, there certainly look to be pockets of children with asthma, and in fact, children with asthma who are having morbidity. In certain complexes, we know there to be problems now. And this then spawned activities like forming tenant associations and grassroots organizing and pressuring landlords to more effectively mitigate the risks known to be violations. So again, showing the power of complementary data informing complementary missions, Children's Hospital, pediatricians, and housing lawyers, housing advocates. And so we've tried to bring this more effectively into what we do every day, thinking about layering information, using data to inform and then motivate us to act. And so I want to run through this quickly for the sake of time, but the layering here we see, it's not just housing. We might inform our other work in thinking about other factors, other geomarkers like poverty or crime or access to care. In fact, what you see here is a layered map. On the top are every emergency department and hospitalization for asthma over a multi-year period. The bottom is Cincinnati census tracts or neighborhoods. One could envision a kind of a dual approach here, starting with a dot at the top and tracing it downward through the different aspects that may characterize that particular neighborhood. An alternative approach may be starting down at the bottom, thinking about a particular neighborhood, tracing it up through those risks, and then understanding at population level what the outcome is. And so if you want to just kind of pop through these, you'll see what these different map layers represent. And then I also illustrate how they may represent a way that could inform the care of the child I introduced at the start. So if you advance, you see that perhaps this might help us think about this child and think about the risks that he may face, that his family may face. Perhaps there's no car, perhaps there's diminished access to something like a pharmacy or to primary care. Perhaps there's housing issues that may be influencing the degree of morbidity he feels. Perhaps there are mental health issues at the base of what that family experiences on a day-to-day basis. All things that have an evidence base in the care of children with asthma. So we advance. Thinking about him from a patient care perspective, we see this possibility as informing how we then act to improve his particular outcomes. It may not just be us providing albuterol and a steroid. It may also be providing medication delivery, connection to a housing lawyer, connection to a peer support group, other things that may have more impact in his long-term health and well-being. And I think linking that place-based data to action can also occur population-wide. So if you go to the next slide, thinking about how it might be used to improve both his particular experience, maybe if you take the housing example, how might improvements be made in his particular unit, in his particular housing location, but more than that, thinking about what type of pattern recognition does this data provide, so that he is probably not the only child with asthma in a building complex with cockroaches. Even if he was, perhaps that building complex shouldn't have cockroaches. Perhaps it's affecting other residents of that particular complex. How can our partners who are expert in these interventions best use that data to support the tenant associations and the collective action that has such promise? And so you advance, if you could advance, this is the area that we're really starting to think about. This map is from the basement of Carmel Presbyterian Church in the center of Avondale. It's one of the ways that they have used for years to figure out where their outreach is for some of the residents within their community. We've tried to co-opt that strategy a little bit in partnership with them and think about using technology to do something similar in medicine and healthcare provision. And so a few other maps that we've created and oftentimes think about with our partners is where are our patients living, what's the medical complexity in those locations, where are the no-shows, where are the emergency department visits, and importantly, where are the assets? Where are the potential partners in the community who are far more adept at thinking through the actual action steps perhaps than I am as a pediatrician? I can be a valuable partner, I may not be the primary actor. So if you advance, this is where we're going as an institution. I think some of you may know that a few years ago, Cincinnati Children's outlined an approach to community health that was truly in partnership with community members and agencies. And here are our four big goals that we have set out as our community health initiative. You can see one is around reducing infant mortality, one is around reducing disparities in inpatient dead days, which I mentioned a moment ago. You see two others that are more on the kind of thriving side of the equation. So one about what does it mean for a child not just to be kindergarten ready, but to be truly thriving at age 5. So meeting their developmental milestones and being healthy from a medical, dental, and eye standpoint and rest. And then the other measure, which was mentioned a moment ago as well, is this concept of third grade reading. So So Cincinnati Children's can be a partner with Cincinnati Public Schools, with other agencies out in the community to help ensure that children are on the best footing forward to improve their care across the life course. Now, in my last couple minutes, I did just want to highlight a couple aspects of this bed day work, because this is the area where I spend most of my time. If you could advance, one of the things we're trying to do is really identifying those hotspots and then figuring out how to cool them. And so this is one of we commonly use, I think I saw that there's a session that looks at GIS later. This is a strategy that we've begun to use to think about where might those hotspots be, how might we cool them. And I couldn't help myself by including this tweet from Francis Collins illustrating the importance of this type of information in not just clinical care and activity, but also in clinical research. And so I think the concept of bringing these points of information to the action table is incredibly timely and well suited. So if we advance, we can see some of the things that we're doing. And we're trying to do this in this kind of mentality that there are activities that can take place at the bedside of an individual patient. There are activities that can be undertaken with households or families, with communities, and then of course with the broader kind of political landscape. And I think, I'm not going to go through these in detail, but here are just some examples of the activities that we're pursuing. And I would say that the quantitative and qualitative data underpin all of them. So if you advance, the last thing that I'll share is how data can be used not just to inform, but to measure outcomes. One of the things that we're measuring is pharmacy or prescription fill rates. Here's a set of prescription data from Kroger by zip code. We looked at the least affluent zip codes and the most affluent zip codes and just looked at medication fills across those particular areas. And across every medication category we saw, there were discrepancies, there were disparities, there were differences. And so just to call out a couple, if you advance, you'll see notation for asthma, but it's not just asthma, it's also epilepsy, it's diabetes, it's medications that are necessary for chronic control. And it's even antibiotics, which one would suspect most people have an acute need for. So again, how can we use these data to take it to our partners to figure out alternative strategies to filling medicines? And then how can we ultimately measure the outcomes that we're trying to achieve? Next slide. And this is the kind of thing that we commonly look at. Again, these are control charts that we follow over time. So we're looking at bed day rates in particular neighborhoods and target neighborhoods over time. The y-axis is looking at those bed day rates month to month. The x-axis is looking at time, where each data point is a particular month, so that we know as close to real time how it is that we're doing. And we're trying to figure out how we can use these data to keep us honest, to make sure that we are providing the best possible evidence for action that we're seeing. And the next slide is not something that I want to dwell on, but it's just showing that we're focused now on neighborhoods like Avondale and Price Hill, but we also want to understand the background trends. And so the same strategies can be used across the city, neighborhood by neighborhood. Eventually, the concept is how can we spread this more fully? And so this is one of the things we look at month to month. We look at Avondale and Price Hill. We also look at Spring Grove and Wind Hills and Walnut Hills and Evanston and other places that might tell us whether what we're doing is having an effect. It may also inform what we do next. You could advance. So I'll conclude here. I would say that data is incredibly important for us both at the bedside in medicine as well as we think about population health and population well-being. I think it can inform and help us understand the extent of the problem. It can motivate us for action, and it can help us to track outcomes. And I think when I think back to this equity figure, I would say that when it comes to data, I think data have a role in helping us to understand, again, the levels that these children are standing upon with the ground, the wall itself, and then the boxes that we try and put into place. So I'll close there, and if we still have some time, take a few minutes for questions.
Thank you very much.
Hi, my name is Charles Connor, I'm a first year PhD student over at the College envision an actionable, like what is our obligation when a lot of these determinants are economic or political in nature?
So the question is, what is our charge, so to speak, if a lot of the health outcome is affected by external factors that are not necessarily in our area of expertise? Am I interpreting correctly? Okay, so here's my response. Because I think it's a tricky question, and it is one that we commonly have to grapple with in hospital settings. I would go back to what our oath is. It was mentioned a few moments ago, and I think our oath, the way I think about our oath as physicians, is very outcome-oriented, right? So we're trying to achieve the best possible outcomes for our patients. Now, sometimes that will mean me ordering a laboratory test, sometimes it will mean a particular medicine, oftentimes it will mean something totally different. And I think this is where increasingly we're trying to think about how to fill that gap. The way that I've started to think about it when I'm seeing a patient either in my primary care center or on the hospital wards, oftentimes I'll listen to their heart and uncover a heart murmur, right? I may not know what that heart murmur is. I'm going to refer that child to a cardiologist or get my cardiology friend on the phone and say, this is what I'm hearing, I need some help. I think increasingly we're advocating and trying to think about how to do the same thing for social, environmental, economic risks. So if I'm in the room and I think quite honestly that the primary challenge that this family is facing, they're coming to me with, that is perhaps influencing their health in the short and also the long term, maybe housing. I think in medicine, we're trying to say, how can we then treat that much like we would a heart murmur that I don't know what to do with? I'm not a housing expert, I don't claim to be. But it should be within my purview to say, if this is what this child needs to be healthy, then I should find myself a housing expert to connect them to and work towards that. So the short answer to your question is that I think we are trying to be increasingly outcomes oriented. And if those outcomes require slightly different care practices than perhaps we've done historically, so be it. Yes?
How do you follow up that question? So do you find that hospitals are using social workers advocates that are really
Yeah, so the question was about how hospitals are using social workers and advocates. I think, so yes. I also think though that this is a day-to-day, so I'll say this. I think there's a tremendous opportunity for evidence generation about what works best and how it works best. I think in children's, we certainly have social workers leading the charge. I think we also have community health workers, community advocates. I think we have medical legal partnerships. We have connections with community agencies and community members. I think we're trying to figure out what works best. I don't necessarily know that we know the answer. I think ensuring that the right people are around the table as we uncover that and then track data to figure out if what we're doing is making a difference is key. Yes? So I think this is great. So the question is around data democratization. So how can we make it useful across sectors, so to speak? And I couldn't agree more. I personally, as a scientist, I would say, and me as a member of a community health team, have been benefited greatly from democratized data from Greater Cincinnati and nationally. We use census data all the time. We use local data on housing code violations all the time. A vision, I think, could be a platform that is totally democratized, that includes whether it's HealthBridge data or Cincinnati Children's data in aggregate, so we can know in more real time than every 10 years with a census or every 3 years with a community health needs assessment how we're doing. And so one of the visions, and one of my colleagues is here who's really active on this with me, is thinking about how do we say in real time have data available to our partners aware of privacy and HIPAA issues, but aggregated, rolled up to either a geography or a demographic or something like that that would be useful. How do we have a platform available for action? Because make no illusions, the hospital alone cannot solve these problems. I think the hospital can be a key leader, a key steward, a key convening power, a key partner, but the action on the social determinants, I think, will require grassroots action by key agencies that are the experts in this, and then parents and families who know their reality better than anyone. So I guess my answer is I couldn't agree more. I don't think we're there yet, technologically, at least internally, but I think that's where we want to go. The one other thing I will say is that many of you may know the Robert Wood Johnson County Health Rankings. Has anybody seen that? It's a I think an interesting site to be able to look county by county. But I think when you're at a level like a county, you lose a lot of granularity, right? So I think one of the places that we're trying to think about this is how can you build and provide such a platform that gets more granular to say neighborhood by neighborhood, that's a little bit more action oriented.
Last question.
Yes.
Hi, I work in the library. I have a question. You kind of hinted at environmental health indicators, but what I was hearing from your presentations for household, I'm wondering if y'all have looked at things like the EPA's toxic release inventory, because that shows us a lot of stuff about where air pollution and water pollution is taking place from industrial sources in the city, and it's in neighborhoods that are on the left-hand side of those graphs. So can you talk to that?
Yes, absolutely. So the question was about other kind of bigger picture environmental exposures like the toxic release inventory from the EPA. Yeah, so I work with some environmental epidemiologists, and over the course of the last few years, we certainly have looked at things like that and see those data as a larger piece of the puzzle moving forward. Things like toxic release inventory, traffic-related air pollution, proximity to roadways. And then we even did a project about a year or so ago looking at CSO, Cincinnati sewer overflow, or combined sewer overflows when we get heavy rains and proximity to Mill Creek and other outflows like that. So I think the idea is that there is data that is fairly ubiquitous that has health impact. Figuring out how to bring it into a central location and then understand its relative contribution is a key piece of the puzzle. So absolutely.
So let me thank Dr. Beck for his comments and the questions. And our last speaker this morning is Doug Phil-Harris. Doug Phil-Harris, Vice President of Customer Strategy and Activation at 85.51, so 84.51, sorry, which is a wholly owned subsidiary Kroger company. He's a specialist in bringing consumer insights into the Kroger our brands business, and he will be discussing the journey from personalized to personal. All set.
Okay, thank you. Okay, a couple things. I'm going to let you take a look at the slide that's up there now. There's a lot of words on it, but I'm going to start with a question. Who can tell me why they think our company is named 8451? Anyone want to take a crack? That's very good. That is correct. So 8451 represents the longitude of downtown Cincinnati. It actually runs right through our building, which is on the corner of 5th and Rice. And we chose that name, one, because I get to explain that every time I meet somebody new, but also because it represents a few things. And some of the things we're talking about here, like immense challenges. It took hundreds of years for mathematicians and astronomers to be able to do the calculations that allow us to use longitude today. We tackle big problems in 8451. We're talking about very big problems here today that we're trying to overcome. So a lot of similarities in what we do as a subsidiary, the data owner subsidiary of the Kroger company, and what all of you are doing here at UC and beyond. Okay, so I'm going to try this because I just like to keep doing that. All right, So a couple things here. This goes back to the telephone example we heard earlier, and just talks about data and how much data there is in the world. Some of the stats up here are things you may have heard before, but in 60 seconds, more than 430,000 tweets are sent on Twitter, right? That's a pretty big number. But over 150 million emails are sent. So we have this example here because at companies like 8451 and our competitors, we are in charge of being able to manage data inputs like that and be able to synthesize them into action. As the quote says, information is the oil of the 21st century, and analytics is a combustion engine, and that's what we do. Okay. The other reason I'm walking through, besides hoping that this will work better, is because my eyesight is not good enough to be able to see all the way over there. All right, there we go. So why is that so important to a company like Kroger and a division like 8451? Most of you are familiar with the different logos up here, but they're kind of clustered lightly for a reason. One reason could be because they are a major competitor of ours. That could be Amazon, that could be Walmart, it could even be Alibaba, which you're hearing more about. We have competitors like Lidl and Aldi that are appealing to a customer that is much more concerned about price and how they're going to get food on the table. We also have mega mergers, Amazon and Whole Foods, Albertsons and Rite Aid was just announced. We have shopper behavior changing, which is represented by Findlay Market. I was just there this past weekend, absolutely packed. But also Etsy, that's allowing people that make their own crafts and have their own businesses to be able to market those directly. And then we have another cluster that's changing how people eat, like Blue Apron, delivery, Uber Eats, also delivery, and then unfortunately for the lower right corner, companies that are not keeping up with the change of customers. Toys R Us, Radio Shack, and unfortunately Macy's that has their headquarters here in Cincinnati. So understanding data in the retail environment is incredibly important. Okay, so how we got here. I'm going to walk through a little bit of what 8451 and a company before us called Dunnhumby USA, how we got to where we are with Kroger. Could you advance that, please? Okay, so this is just an infographic that gives you an idea of the scale of the Kroger company. And there's a couple things on here that may be of interest to some of you, namely in the middle, that we have almost 181 million prescriptions filled on an annual basis. Right? So we have over 2,700 grocery stores. We have food production plants, 38 food production plants, ranging from cookies to milk and everything in between. Distribution centers, we're now up to almost 50 distribution centers across the United States. So a massive company, but the point is, through a lot of different ways, we have touches, physically and data-wise, with people all over America. Please advance. Okay, so how does all that work? How do we take, producing milk and cheese and things and bring that to data? Well, it's all about the Kroger Plus card. How many people here use their Kroger Plus card? Darn right. Love being in Cincinnati. All right, that's great. That was an easy one. So you visit the store, you have your Kroger Plus card, or you punch in your number, what have you, and there's an exchange of trust that just happened right there. So being a Kroger company, when we ask for your data, you're putting trust in us that we're not going to let that data get out in the world, but also that we're going to do something with that data, with that exchange. The easiest thing that we're going to do is we're going to give you a lower price on your items. I think we all understand that. But it's also going to be things like using that data to help the shopping experience be better, to make lives better, and that's better for us as employees, but definitely for our customers as they come into the store a couple times a week. So that is the main exchange of trust and value that we have between our company and you as customers. All right, so a lot of people do that. And on an annual basis, we have over 60 million households come into the Kroger company, ranging from now Florida all the way to the Pacific Northwest and even beyond to Alaska. That's 1 in 2 households in the US, and that number continues to grow. So what we know is a lot. And you know a lot about somebody when you're scanning it, and we mine an awful lot of data. Millions and millions of transactions, and you can see some of the things that we find out. Did you buy it with a coupon or not? What time of day did you come in the store? How many times a week did you come in the store? Did you spend $80, $30, etc.? And of course, when you know those higher level stats, you can start breaking it down and understand, do you have kids in the house? Do you have someone who maybe is gluten-free in the house, and it goes on and on and on. Okay, this is another breakdown of some of that data, but the key point here, besides saying again how many households come in, is we don't do this work on our own. We have division partners with the different logos of Kroger on the first line, but more importantly, what I wanted to show is our data model is built in a way that we share with partners, like these logos, Unilever, Dannon, Del Monte, Procter & Gamble, where they actually have access via portal, like a lot of libraries and things do as well, for them to mine data, use that within their own companies to improve new products, to follow trends they may see in that data. Gluten-free is not so much of a trend anymore, it's here. Well, years ago, that was mined through data like ours to understand, wow, we got something here, we really need to bring more products. That can even extend into the healthcare area. I mentioned prescriptions earlier. We have a lot of partners that we're really starting to get going with. Thank you for the Kroger slide, Dr. Beck. That was an excellent example of that. But those partners as well is where we're really starting to scratch the surface of using that kind of data. Please advance the slide. Okay, so how we built this, where we were, is focusing on loyal customers. This is what we've preached to Kroger for many, many years, and one key reason why they decided to buy us. One loyal customer in Kroger, so someone who visits probably about 2.5 times a week and spends maybe $80 per visit, something like that, is worth 8 non-loyal customers. So we are constantly focusing on improving the experience of that loyal customer, and then that radiates out amongst everyone else with the hope and the proof that we then get more loyal customers and we're a successful business. Please advance. Okay, and this is how we break that down. So this is a very simplified version of a loyalty segmentation that we use. And you can see people that are uncommitted do not spend as much, they do not commit as much. And as you move across those two axes towards premium loyals, we tend to focus more on the pink or fuchsia colored and the orange pumpkin colored. That's where we spend most of our time, because that's where the value is for us, but we also know so much more about those people and can engage the way they want to. Okay, please advance. Okay, so today, that's what we've been doing and got us to where we are, but here's what we're doing now. So please advance. Okay, shopping is complicated. I think we all understand that. I would venture to guess that someone in the audience at some time today was on their phone buying something. We weren't doing that a few years ago, but you can go right across in the Tangeman Center and you can purchase. You can go to the new Kroger Clifton. You can do all of that on your phone right now. And this diagram shows all those choices that every one of us at some time is making while you're trying to buy products for yourself or your family. So it's up to us to make that not so complicated for you. Please advance. And how we do that is previously we focused mostly on behaviors. We know the behaviors, we know the loyal customers, we know the segmentation, so we're kind of starting in the middle, and then we're moving to baskets, which simply means how much you buy, and then unfortunately for Kroger, we tend to make money off of those transactions. Where we're really beginning to focus more, and Dr. Brennan was mentioning some of these things when she was talking, is we need to understand more of the attitudes. We tend to call this thick data, the reasons why behind the reasons, the why behind why you buy. We need to know more of that, and that I'll get into a little bit more, but that thick understanding of human nature and reasons why you do things is what we need to know. Please advance. All right, so this is taking another view of all those things that are going on. We want to be able to see the customers in the data through their behaviors, right? How you shop, where I am, influences. And friends are still influences for sure, but more and more we see influences coming out of social data, response data, network sentiment. Attributes is very big for us. That provides a lot of thickness, not just on the attributes of people, but very much on the products that we sell through our stores. And then, of course, motivations. What is it about you that causes you to do things? As you can expect, in a person's life, there are certain life stage changes that really are going to change your behavior. Getting married, buying a home, having a child, death in the family, divorce, all those different kinds of things really, really impact how you shop. And we work very hard to capture what we see change in your purchases with other things outside so we can put some context behind why you changed. Please advance. So how we do it. We have a bunch of scientists. Yes, that is absolutely true. We have over 700 employees at 8451, and we're a very rapidly growing company. I'm happy to report we recruit more people in our company from UC than any other college in the United States. So we are bringing in data scientists, we're bringing in economics majors, all those kinds of people. But really what changes it are the values. And we bucket them in limitless minds, fearless hearts, and relentless delivery, which are some fancy ways of being able to say, think about what's possible and go do it, and do it in a way that's going to make a difference. If we do that right, then we are definitely putting the customer at the heart of every decision. That's back to that value exchange that we make with you every time you swipe your Kroger Plus card. So please advance. Okay, so what does that mean for us? These are just some simple examples of things that we do every day that come to life in grocery. Whether that be the items in a store or maybe a type of store. It could also mean how we send coupons to you. People are familiar with the coupons, you're probably familiar with fuel rewards. All of those things that seem sometimes trivial or you just kind of forget about are really rooted in mountains and mountains of data that we go through. Please advance. And even new ways. So getting coupons in the mail maybe seem like something you've been getting for a long time, and that's why, because it has been, but it's changing. We have things like off-site media where you will be on another website and we will flight things to you that encourage you to look at Kroger. Social media, direct mail still exists, but now we're very much focused on things like ship to home and click list, which is a curbside pickup service that again, we have to make as relevant to you, not your neighbor, not your friend, but to you as we possibly can so we get you into one of those loyal buckets and we have a really good exchange of value. Please advance. Okay, so a couple more slides. The opportunity, please advance. Okay, so why we need to do this is we need to move beyond, I kind of like Kroger, I go to Kroger, but I also go to a lot of other retailers, is to move those people that do shop 6 different retailers to get Kroger to be in their top 3 or in the upper box. If we can do that, we receive 80% of that customer spend. That's a really big deal. But the only way you're going to do that is by being very personal to that customer. You have to make it work for them. If they want to pick up their groceries, you got to have it. If they want to ship to their house, you got to have that too. If they still like coming into the store or they got to do it in the middle of the night to get medicine for their child, you got to be available for them too. So all of that work continues to happen so that we can continue to move people to love Kroger. Please advance. And then the new layer of data. This brings me back to the comment about thick data I made before. So living it, getting in the field, getting into the lives of people, really seeing how they live. Maybe it's a household in Avondale right up the street, or maybe it's one out in Anderson. Very different places, but very different motivations. And we need to get beyond just the numbers so we can apply that thickness to what we see. We make sense of that life data by combining them, and then we take action by actually doing something about it, either ourselves through our Kroger stores, or with our partners like the Sargentos or the Glaxos of the world. Please advance. And then from here, as you can see, some of the things on here I've kind of hit on. Very functional on the bottom left. Point of sale market, the traditional grocery kind of thing you would expect and you've seen for a long time. But as we move to the right and we include thick data, that's where we move more and more to the personalized side, and we'll just see more personal interactions in that value equation grow. So please advance. Okay, please. So understanding based on needs. I was just going to focus on the care for me, the one right in the middle, because what we see here, instead of focusing on segmentations that tend to be more demographic, how old people are, how many kids they have in their house, what this is saying is bringing in that thickness. So care for me. For this audience, focusing on nutrition, whether someone is weight conscious or maybe they're into clean eating, maybe like the paleo diet or those kinds of things. That's where we are now. That's what we're moving into. It's the combination of what they're buying. Can we predict how healthy somebody is going to be next year by what they're eating? I'm not a scientist like many of you are, nor am I a doctor, but I think the answer is yes. We can really have a valuable input with that kind of data. This is how we're starting to break that down and bring that thickness into it so we can understand the challenges that these people have. And you can see the other 4 pillars as well. So, customer behavior, that's where we've been. The teal color, those needs, that thickness, leads to the 3 pieces in the middle. Customer lens being improved, incremental opportunities, and recommendations that we can actually make to customers, very much like doctors do now, more in the food space though. That results actually in an uplift for us as a Kroger company. That's where that exchange of value really comes to life. Please advance. And then this is the last piece, where it's really just saying, back to that idea of spend and visits, pretty basic math. You do that right, you put the thickness on it, you're going to have upside opportunity being much greater than what you see with the risk. Please advance. And that's what I have. So thank you very, very much.
We have time for some questions and comments.
I just wanted to ask, with your emphasis on big data now, what is your take on the struggle to draw meaning out of numbers? I guess what I struggle with statistics in general is that you can say, okay, somebody bought X product, but that doesn't necessarily mean they're having a Super Bowl party. That may be going on a healthier diet, whereas a Super Bowl party would be more fried chicken and stuff. So how do you move from data to this is what the data is?
Yeah, the thickness definitely is a piece of it, but it's a combination of a lot of things. I'm sure you're expecting to say both or something like that. But it's trending over time. So understanding how this was before, simple things like your example, what time of year is a pretty basic thing to start with, but it's not going to be enough. It could be a healthy diet that the person is eating avocado or salad on Super Bowl Sunday by themselves. That's not exactly the party. So understanding their total basket, what else did they buy with that item, would be a key indicator. Basket information is probably one of the number of things that our CPG partners want to understand. But understanding that customer a longer period of time. What I mentioned is life changes. You may, in college, be turned on avocados and make it walk away. But then as you move into your 20s and you start taking better care of yourself, you start buying guacamole, the avocado itself. So a change like that can be interpreted of a lifestyle change, so we're going to start marketing that person in a different way. And that will come to life by, if you're eating an avocado, it may not be much of a reach that you're interested in quinoa as well. Right? So you can see how this starts to build. But that thickness, while maybe you're not, I'm not talking you specifically, we are seeking out to understand how are people that are trying to either have parties, there are a lot of people that like to do that, it's a very valuable customer segment, and conversely, people are trying to be healthy, really getting in and seeing what their motivations are and why they lie what they do. And you have to apply that to the people that we see in the behavioral to make that match. Make sense?
Yeah, it does.
Okay. Yes, please.
How is 8451 determining what you're talking about, the life events for their customers that are outside of the food industry that affect I'll give you an example.
Okay, please do.
You buy a car.
Okay.
The car is electric. You pay for it, or Kroger doesn't have charging stations. Walmart does. How would 8451 Kroger use that data?
Yeah, so it's funny, my wife actually owns an electric car, and the Oakley Kroger does have charging stations, but I'm told by her they don't work very well. She's actually sitting right here. So she'll tell me about that story later. But we partner with a lot of companies because we know darn well, although we have data on 60 million households, we do not have enough data to complete the absolute picture of what's happening in customers' lives. So we have partnerships with companies. You may have heard, I'll give an easy example, IRI. In the past, we worked with Nielsen. We work with catalog companies. They still exist, you can believe that. They have a real thickness of data. And then occasionally, if we were to go into some kind of a project to understand the behavior of a trend, like, wow, people are buying electric cars, what does that mean? We have partnered directly with firms that are interested in that kind of data. Now, there are a lot of rules behind such a thing, because as I mentioned, we hold the Kroger Plus Card data very tightly, and exchanging of data on the household level is absolutely not allowed. So we intake, we combine it, much like with the thick data, and that's how we come up with recommendations. So I hope that answers your question. The partnerships are key to all of us.
I think it's really interesting to put you with the health professionals on this panel, because when I think of going to a doctor, I can get my data back, right? There's sort of like a two-way trust street, I guess, with physician and health professional. But with 8451, I'm a very, I guess, loyal Kroger customer. I love Kroger.
Thank you.
I love that they're unionized. I love going to Kroger. Sure. But can I find out how loyal I am before I go past it?
No. And the truth be told, I'm not allowed to find out either. Right? So we have, there is, we have a lot of laws, HIPAA being one of them, that you all understand that affect how much data we're allowed to share. It was interesting listening to the panel of doctors, and I'm the only one that's not a doctor on the panel. But you don't have to dream too hard to see the powerful combination. I'm very happy to report that Kroger, one of the charges they've given in 8451 is to dive into the health space. It is not an area where we are ready to release all the work to the world, because it is so hard to do what we do and be respectful of privacy and to be respectful of laws that keep us from oversharing and things like that. So it is something we hold very closely, but the kind of buzzwords that we use is food is medicine. And if we can help people that have a need, gluten-free, they're diabetic, whatever the example is, if we can find a way to encourage them, to make it easier for them to get the foods they need, and then see that all the way through to when it gets to a state of they need a prescription or something like that, and we can close that loop for them, I think it can make everyone's lives a little bit easier, and that's what we want to end up doing.
So does Kroger then take this data and use it to design new stores as well? Decide if they're going to drop a brand or add a brand, or change shelf placement, or move the laundry detergent from this side of the store to that side of the store?
Yeah, so the question was if we use the data to really impact changes at store. The answer is yes. And I'm sure everyone has their story of, wow, they just changed my store around, and it's like the worst day of their life, because it's very stressful. I know, I've been there. But yeah, that is a key thing that we do. It ranges from site selection to what type of store. Is it going to be a big marketplace store like Oakley? If you haven't been to the Clifton store, which has 2 floors, it has more international, ready-to-eat foods than any store I'm aware of in Greater Cincinnati. There's a lot of data that goes into that. Where do you put one category adjacent to another, et cetera, et cetera. So all of that is used by our data. Actually, there's one back here first. Go ahead.
So Kroger is an industry for profit, which is obviously means that you guys have very different philosophies than the nonprofits and the hospitals. What I'm kind of curious about is you've done a phenomenal job of gathering partners at an institutional level. It's as seen with the nutritional initiative that's being taken and you are partnering for nutritional panels that will assist in neighborhoods. What I'm curious about is how are you doing, what's your philosophy for partnering at the investigator level? For example, if Dr. Beck, who has all of this asthma data, wants to look in the exact same neighborhoods at vitamin D purchasing at an aggregate level, do you share that?
We have partnerships within our science teams that are scratching the surface of that. And I was very pleased to see Dr. Beck's slide. I do not work in the science wing. What I'd say to it, though, is that's where we're headed. And it's, sure, it's it's altruistic, getting my wording right, to want to do that, but it also makes business sense. The slide I had up there with the different company names, they're moving into health. And Amazon and Google, as some of our biggest competitors, are pushing hard into health. Albertsons and Rite Aid just merged. It's not because Albertsons wants to have a drugstore on the corner of America. It's because they want to get into healthcare. So that is happening. So finding new ways to do it, not just working with prescriptions, but getting into the data itself, the partnership of what we can provide and what research institutions like UC can provide is where we have to head. Not my area of specialty, but working with Dean Wang and others on the other side of 8451 and the talk we heard about 1819 up the street earlier this morning, that's exactly where we need to be going. So I already have a mental to-do list from the conversations that I've heard already this morning.
Last question?
Sorry.
I want to know about some looking into data, and they're trying to figure out how to get people into the pharmacy. You got to look at the data differently. The pricing wasn't doing it, was what they ended up, how to increase the traffic in the pharmacy area, is actually open the pharmacy earlier, you know, the actual drugs and stuff like that, and increase the traffic. So you got to figure out how to interpret your data too.
Yeah, I couldn't agree with you more. I mean, you can have mountains of data, but if you don't have the people and the skill set to interpret, it's useless. And you know, people like myself that are consultants, that's what we are paid to do, to help analyze that. It is funny how sometimes it is the most obvious things, you know, open a little earlier, have your pharmacies in the right location, that really do make the difference. But that's exactly one of the reasons, besides being able to mine physically or electronically mine the data, that actually we bring the people to help interpret it as well. And that's how we're moving out on the curve over the past few years.
Tiffany, do you want to close us?